Hello, good morning, everyone. Happy 6 a.m. So you are here to hear, hopefully, fueling the critically ill. But here, today we're talking about balancing feeding challenges and individualized nutrition. Just to get these out of the way up front, we have several disclosures, mainly Baxter. For both Pellicati, Modir, and Yeh, I have a couple of also non-financial disclosures, and I promise you that all clinical recommendations are evidence-based and free of commercial bias. Here are the learning objectives, and what I've learned from public speaking is when you have this much text on the screen, it's not worth it for me to read it to you. So I'm just going to leave it up so you can take a look at it. Okay, so for the first 15 minutes, I'm going to talk to you what you've probably experienced every day in your practice, which is feeding challenges, and we'll kind of talk about some of the high-impact studies that have come out in the past 20 years that everyone's talking about, all right? When I am starting nutrition on a patient in the ICU, I like to put things in the framework of the medication safety, the 5 R's. I didn't invent them, but there they are. And really, you have to hit all of these points in order to deliver nutrition properly. How much are you going to prescribe? How are you going to give it? When are you going to give it? How bad is this patient in terms of their baseline nutrition status? And also, if you're giving tube feeds, how much are they actually absorbing? Like, it's going in, but really, is it getting into the bloodstream? To start, the right patient, we only have so much bandwidth, right? And so we really need to kind of focus on, like, who are we going to really focus our ATP on? And so for some patients, I'm sorry to say this, but nutrition doesn't matter, okay? I'm a trauma surgeon, and I get that, young, healthy patient who's there for like Q1 hour neurochecks for a little head bonk. They're going out of the ICU in 2 days, no matter how much nutrition I give them, it's not gonna make a difference. On the other end of the spectrum, we have the patient demented, nursing home, metastatic cancer. Doesn't matter how much nutrition you give that patient, they're not gonna do well either. But, as we'll see later on in the case presentation, there are some patients where nutrition really does matter. We have to be very detail-oriented in everything, not just nutrition, and we have to get it right. And those are the ones that can thread the needle and have a really good outcome despite all the cards being stacked up against them. And that's where, you really want to focus your effort and attention. Now, in addition to age and comorbidities, weight seems to play a role in terms of how much is this patient really going to benefit. So when you're looking at nutrition studies, particularly negative studies that showed no difference, take a look at their BMI. This is a study from the Canadian group, and they kind of, the curve is really talking about the association between the amount of calories they received and their outcomes. You see that some have a very steep negative curve. Those are the ones that as you go increase the amount of nutrition, their mortality plummets. But there are groups there we have a very flat curve, meaning it doesn't seem to be as strongly correlated or associated with how much nutrition you give them. Their mortality doesn't change a whole lot, right? So keep that in mind when you're reading prior studies and any new study that comes out. What was the BMI? Now, we all know that that's not like, it's a very blunt measure, but oftentimes it's all you have, right? Another question that always plagues us, especially if you don't have an indirect calorimeter, is how much to prescribe, right? And so we're all very familiar with the European recommendations as well as our own American ASPEN recommendations to use indirect calorimetry. Well, that's great. But again, from Darren Hyland's group, this international survey, this study is now 15 years old, but guess what? Not a whole lot has changed in the past 15 years. When I go around and I ask people, a small minority of people in the audience have access to an indirect calorimetry. In this case, it was less than 1%, okay? So, yes, it is the gold standard. But guess what? Hardly anybody uses it because they don't have it. So what are we all using? Well, recognizing that it's not, widely available, then the ASPEN recommends, okay, well, if you don't have it, you can use a predictive equation or a simplistic weight-based equation. And in fact, that's what most of us are using. Most commonly 25 to 29, but also Harris-Benedict and some others. So yes, if you're using it, you're not in the minority. In fact, pretty much everybody else is using it. Now, the problem is I could go in for a whole hour about the flaws and how they're derived. I'm not going to. But just understand that they don't change over time, right? There's not an equation that says, well, when they're in the early acute phase, you give this much, and then when they're in the chronic recuperative phase, you give that. So they're static. And by the way, statistically, they're almost always, like if you were betting, if you were going to gamble, you'd bet against them in terms of accuracy for any one given patient, okay? You're almost always going to be over or under feeding them to that one patient in front of you. But if you use the same equation over time, you'll balance out your overfeeding with your underfeeding. So for populations, it smooths out, but for any one individual patient in front of you, using an equation is not going to be accurate. And why is that important? Because it's a U-shaped curve, right? Just like most things in medicine, there's like a Goldilocks right in the middle where, that's the best, the lowest mortality, and then as you deviate from that, as you go away, if your blood pressure is too high or too low, that's like not good, right? So same thing with nutrition. You want to be not too high, not too low. There are negative consequences of both. All right. What about the route? Okay. Many of us, myself included, are trapped in this sort of either-or mentality where we think that EN and PN are mutually exclusive. Guess what? They're not, okay? And I think that, we're starting to see the pendulum shift from one extreme to the other, and now we're all becoming much more comfortable with using both modalities. Now, speaking of TPN, I'm on a personal crusade to reduce the stigma that's attached to PN that has sort of been unfairly attached to it from the way that it was delivered in the 20th century, right? So anything prior to 2000, we didn't know. I mean, no offense to them. I wasn't practicing medicine at that time, but no offense to them, but they were still learning about all the negative ways in which PN can be delivered, okay? And so I think that, we've come a long way. And the things that we used to do, prescribing outrageous amounts of calories, not caring about the glucose, we didn't know about chlorhexidine and catheter care bundles, et cetera. Everybody was mixing up TPN down in their basement, cigarette in their mouth, no gloves. Those days are gone, right? And we only had one form of lipid at the time, which we all know was pro-inflammatory. Now, apologize. This is the best I could come up with for 20th century. Next time I'll use AI to generate like a really cool slide, but this is what we do now, right? And you want to pay attention to studies that look at modern 21st century TPN. One of our friends here in ASPEN, Carol Braunschweig, published this 2001. This was the state of the art at the turn of the century, okay? And I'm sorry that the font is so low, but I had to include the titles and stuff, but that column is the infectious complication rate for PN when they're directly comparing head-to-head EN and PN. 84%? That's insane, right? So that was the state at that time, and it's no wonder that people developed, rightly so, hesitation to use parenteral nutrition because it was indeed, but it wasn't per se the TPN, it was the way that it was being delivered. All right, now, after 2000, there were several really wonderful studies that came out looking at modern TPN care. They do have some flaws in them. I'm sorry to say if anyone in the room was participated or designed them or led them, but I think that we've learned from that and we can take it forward. So the calories trial compared TPN versus full enteral nutrition, okay, and this was known as the calories trial. I'm just doing a very high overview. The French group did the Nutrivia 2, looking at unstable patients, okay, ventilated and on pressors, comparing TPN versus full enteral nutrition. This one doesn't have a cool acronym, but I call it the DOIG, the Australian-New Zealand study. This one looked at early TPN versus early NPO for patients who had a relative contraindication. The Belgian EPANIC trial, led by Vandenberg's group, looked at TPN versus inadequate. So this is really basically the ASPEN guidelines versus the ASPEN guidelines. Like, when do we start supplemental? Do we start on day 3 or day 8? And then my favorite is the Swiss SPN trial, which I think we'll hear more about later, right, from one of our next speakers. So this was the Swiss group, Heidegger et al. I've compiled this table that basically shows that The first thing I want to point out is they all looked at mortality as an endpoint, which is a very blunt measure, and it's also it's a setup for failure. You're basically doomed to fail in ICU. So less than like 5% of ICU studies looking at mortality actually showed a positive mortality trial. So first of all, don't just read a negative superiority trial as equivalence or non-inferiority, okay? But secondly, I want you to look at that last column where it says infectious complications, okay? With the exception of the ASPEN trial, all the others have shown no difference in infectious complications with modern TPN care, okay? We're talking about 1%, 2% incidence, not 84% incidence of infectious complications. All right, with the ASPEN, we can talk about it later. I know that Rana is going to mention it as well. We can also field questions about it, but I tend to think there are some peculiarities about the style protocol that, for me, make it a little bit, I'm a little bit hesitant and reluctant to apply it to my patients. Okay, so in modern 21st century TPN care, which I know all of you are practicing, you can rest assured that you're not harming your patients, at least not according to the highest quality evidence that's available out there. All right? And the final thing you have to consider, well, not final, but one of them is like, how much are they actually tolerating, right? You're putting in 1,800 calories into the gut. They haven't had a bowel movement in 5 days, right? Ileus, opioids, intubated. How much of that is getting there? How much is just sitting in the GI tract at third spacing, right? We don't know. One thing that I've learned in my journey as an ICU physician is that, really, I should just relax. During the first 2-3 days, just relax. It's okay. The body is doing endogenous gluconeogenesis, whether you give that patient nutrition or not, okay? And what we've learned is that we've kind of focused our lens on the wrong phase of critical care, and that all this attention, the calories, natriuria, DOIC, ASPEN, they all focus on that early acute phase, when really what we've learned is that that's not the most important time to be focusing on nutrition. We'll get some more at the end with practical recommendations. The Swiss SPN trial waited until day 4 and day 4 through 8. And what was interesting was they focused on mechanistically plausible outcomes, endpoints, which they looked at nosocomial infections starting on day 9, day 8 or day 9. I was like, okay, that makes sense. It doesn't make sense that you would start calculating infectious complications on day 2, right? You just started TPN last night. That doesn't make sense, right? So this is what I really like about that Swiss trial. This is a graph that was drawn by our colleague Paul Wischmeyer, and this is really what I'm talking about in terms of static versus dynamic, that you should evolve along with your patient as their course progresses, assuming they survive, right? And so early on, you have a strong contribution of the endogenous, and so you should just relax. Just relax, it's okay. Come back in 2 days. If they're still alive, now you can start ramping up. You can start increasing your protein, your nutrition, and then especially once they get into the second week of critical illness, or if they convert to that persistent inflammatory catabolic state or chronic critical illness, that's when I think it's most important to stay vigilant. Okay? In terms of the absorption, we know that a large proportion of patients have enteral feeding intolerance. Okay, it's even higher in surgical patients, but at least 1 in 4 of your medical patients have intolerance. And so that's why I think that we should be, embracing the both and approach, not just the either or when it comes to EN or PM. And then in terms of absorption, I just want to highlight this. This was from one of our group of friends from Mass General, where during the COVID pandemic, they actually used the acetaminophen absorption test, which is a validated marker of gastric emptying. They used that to look at their patients, and what they discovered was that, in fact, many of them had very low acetaminophen absorption. So really, how much are they absorbing their 2 feeds if they can't even absorb Tylenol, right? Okay. Once you've gotten all that figured out, okay, now you have to follow through. And that's often the hardest part. You have a plan, we're going to do this, now let's follow through, right? And again, from Highland's INS survey, we know that the best, it's possible. There is one ICU out there, just one, that can actually get 100% of what they say they're going to get by day 4. For all the rest of us, we kind of top out at around 60%. Okay, so when talking about adequacy and inadequacy, that's sort of how that looks over there. And so there are several reasons for nutritional inadequacy, and I've kind of categorized them into 3 main categories. Delayed initiation, which at this point we actually know is not that big of a deal, in the early acute phase. Insufficient prescription, you're just not giving enough. And insufficient delivery, which is probably the most common, right? And so when you think about the reasons for it, low prioritization, insufficient or outdated knowledge is shared between this. And if you're in a surgical ICU, you also have to contend with the ego of the surgeon who may or may not know the first thing about nutrition, but usually has very strong opinions about it. And trust me, I've been on both sides of that divide. I've been the surgeon, I've been the intensivist, so I know what we struggle with. And then finally, with the insufficient delivery, we have protocols that may predispose to prescription or under delivery, unscheduled interruptions, and again, this black box question mark about absorption. So basically, to wrap up my introduction to the next 2 speakers, we've had some great trials. However, they enrolled very few malnourished patients. They focused on the early phase when nutrition probably doesn't matter all that much, or as much as we used to think. With the exception of one of the ones that I put up, they all used inaccurate methods of calculating or estimating the amount that they needed. And they used a very blunt endpoint, mortality. But my takeaway from all that is that in modern day practice, TPN is not associated with increased infectious complications. So I'm going to plant the seed of the case. Okay, we're going to come back to the case at the end as a jumping off point for our discussion. But just imagine you have a 63-year-old man, medical history, diabetes and chronic kidney disease, who undergoes an operation that had some adventures intraoperatively, let's say. Okay, so they had some events. Now this patient is quite sick. They're in your ICU. They're in continuity, their GI tract is in continuity, however, they're on dual pressors, and because of all the resuscitation, they've got their 20 kilos up from their baseline weight. All right, so the patient is now oliguric, acute on chronic AKI. They're intubated, they're on lung protective ventilation, sedated with propofol, and now they're feeling the effects of ischemic hepatitis, and their pressors are, as you see them right there. So I'm not going to poll you, but I want you to think, how much would you prescribe this 63-year-old man 20 kilos up? What is his protein target? And which route would you provide their nutrition?